All right, good morning, everyone. Welcome to another Friday morning AMSSM Sports Ultrasound Case Series. Today, I have the pleasure of welcoming Dr. Stephen Schaaf, who will be presenting on carpal instability. Dr. Schaaf's completed his PM&R residency as well as a sports medicine fellowship at UPMC, and he is now an assistant professor in the departments of physical medicine, rehab, and orthopedics at Vanderbilt University Medical Center. I also, briefly a couple of weeks ago, introduced Dr. Schaaf as, he'll be taking over the AMSSM Sports Ultrasound Case Series. And so I thought having him present kind of midway through this staff presentation cycle would be a great transition point, and he'll be kind of taking a little bit more of the lead going forward for the remainder of this cycle this fall. And so I'll turn it over to Dr. Schaaf to start presenting.
All right, thanks, Brennan. Are you able to see that okay?
Yeah, that looks great.
Perfect. All right. Well, let's go ahead and get started here. So as Brennan mentioned, I'm going to be discussing carpal instability today. And so for this lecture, I have no financial or other conflicts of interest to report, but do want to kind of do a special thanks and a special plug. Earlier this year, I had the chance to be a part of this paper that was discussing the evaluation and management of carpal instability. This was then published in the current Physical Medicine Rehabilitation Reports. I had the kind of great luck of working with these group of authors here, Dr. Ryan Way, Dr. James Gardner, Dr. Brad Hill, who's my surgical colleague here at Vanderbilt, as well as then Dr. Zach Bailowitz on this paper, which definitely kind of gave me a lot of the information, for my talk, and definitely increased my knowledge of this topic. And so a lot of the things that we're going to be discussing, especially for some of the kind of teaching points, can be found, within this paper. So just a quick plug if you're looking for a good review on this topic. This was just published earlier this year. So the outline for the talk today is like the other presentations, we're going to be going through kind of a case to begin with here. We'll then discuss scan considerations specifically for the dorsal wrist, going through the typical protocol that I'm going to be using for the dorsal wrist and especially carpal instability. We'll then be reviewing the images, and then lastly be going over the report, and then at the end we'll have kind of a very quick discussion and then question and answer session for this. And so the case that we had was a 49-year-old right-hand dominant female who had a history of chronic left dorsal wrist pain and popping. And so the history with this is that it had developed around 4 months earlier. She worked as a air flight attendant, and so she was lifting some heavy luggage. And when she did this, she immediately felt a pop, which was then followed by dorsal wrist pain and swelling. And then really over the next several months, she had been seen by plastic hand surgery here at Vanderbilt, who had kind of managed her symptoms. And it was noted that on her physical exam, especially still even when we saw her, she was still primarily tender along the dorsal wrist. And then really pertinent positives from the physical exam is that she still had pain reproduction with wrist extension loading, specifically over that kind of dorsal wrist. And then additionally, the Watson test was notably positive for pain when we did this, but it was negative for kind of true subluxation and having a thunk. And so, as I had mentioned, this patient had been seen up to this point by plastic hand surgery. So it actually had pretty extensive imaging to this point, which was both a left wrist X-ray, which demonstrated no acute osseous abnormalities or chronic abnormalities. And then she additionally had undergone a left wrist MRI without contrast to this point as well, too, which demonstrated a partial TFCC tear. But it was felt that this really didn't correlate with her symptoms since most of her pain was along that dorsal wrist. So it was really at this point that, my plastic hand surgery colleagues were still trying to kind of search for an answer and diagnosis for this patient. So she was sent on to us for a diagnostic ultrasound. So I think for, some of these scans, and when you get these referrals, I mean, the first question, especially that some of the colleagues will ask is ultrasound going to be useful in this scenario? And I definitely think for a case like this, especially where you're having the dorsal wrist pain, but plus popping, that it potentially is more of a dynamic issue, then ultrasound is really going to be ideal in these scenarios to kind of evaluate for any type of instability, especially. And then in addition, just over the last, several years, with the advances in ultrasound technology, just the resolution for a lot of the transducers and machines are now at such a high level that it actually gives extremely good detail, especially for the ligamentous structures within the wrist and hand. Other considerations, and when we're kind of going into the scan, is always kind of transducer selection. And so usually for these scans, I do kind of flip back and forth between a high frequency linear array transducer, which we see kind of on the upper right here, and then a high frequency small footprint, or that kind of hockey transducer. And in general, what I'll do is usually I'll start out with just the linear array transducer to kind of get a lay of the land, since it has a little bit of a broader footprint. And then especially then too, if I'm going into any structures where I want a little bit more detail, or if I do start to see pathology, that's when I will start to kind of switch over then maybe to the hockey stick transducer for a little bit more detailed evaluation. And then typically for positioning for these patients, I'm going to just have them laying supine on the bed with the wrist in a pronated position. All right, so then like some of the other talks, especially the one that we just had last week, this is still the kind of typical protocol that I'm going to be using for the dorsal wrist, especially if I'm concerned for any type of carpal instability. And so for this protocol, I'm going to be going through the entire 6 extensor compartments, as well to then evaluating for any type of intersection syndrome that can be occurring both proximally and distally in these areas. But on top of this, I do take a very detailed evaluation of the distal radio-ulnar joint, the radiocarpal joint, and then usually then as well too, and last is going to be the scapholunate joint ligament, and then evaluating for any type of dynamic instability, just because this is going to be the most common cause for carpal instability in these patients. However, there are definitely a lot more optional structures that you can scan depending on the patient's clinical presentations. They're going to be a little bit more advanced. One of these is going to be lunotriquetral joint ligament and dynamic evaluation of this area, which is usually going to be the second most common cause for carpal instability. But also if they're having more ulnar related symptoms with this, you can evaluate the ulnar carpal joint, the ECU, as well as the TFCC. And of course, if you're concerned about any type of neuropathic symptoms, then in this area, you're going to have the superficial radial nerve, as well as in the posterior interosseous nerve. All right, so now we'll kind of start to get into the protocol and images for this case. So I think, when you're starting out, it's always really good to use a home base if you can for a lot of these different regions. That way you kind of have an area that you can kind of always go back to and figure out where structures are, especially if there is, pathology. So for the dorsal wrist, I'm always going to be using Lister's tubercle. This is obviously going to be then breaking up the second and third extensor compartments in this region. And really then I'll start my scan from here and then start looking at the extensor compartments. So then first I'm going to go then more radial, and we'll look at that first extensor compartment containing the APL and the EPB. So this is images from this case. And once again, this isn't demonstrating any significant tendon tears or tenosynovitis that we're seeing here at this location. Next, along with that first extensor compartment, then I usually evaluate this dynamically. So we're going to be going more than kind of proximal to that Lister's tubercle. And this is then where we're going to be seeing the first extensor compartment cross over that second proximally. But notably, we're not really seeing any dyskinetic motion in this case, or any kind of fluid collection at that area. Next, we moved on to the second extensor compartment for the ECRL and ECRB at this location. And once again, no significant abnormalities were seen in this case. But originally it was felt like potentially because of the history of trauma that this patient may be having some type of intersection syndrome, especially involving the EPL. And we had a case just 2 weeks ago discussing these EPL tears that they can occur through attritional trauma. So it is possible that potentially they did have an EPL partial or complete tear that might be flipping over that second compartment. But when we evaluated this distally for intersection syndrome, we were seeing an intact EPL and then no dyskinetic motion or fluid collection as we were scanning dynamically for that going over the second compartment there. All right, and then now once again going specifically more into the third extensor compartment and the EPL. Once again, not seeing any abnormalities at this location, and once again we had scanned that distally as well too for any type of intersection. Next, we'll kind of slide over more ulnarly, and then we're going to be going to the fourth extensor compartment for the EI and EDC at this location. So we see those kind of tendons sitting at that home base, but additionally, then we'll continue to scan those down distally. Once again, evaluating for any type of tendon tears or tenosynovitis that may be present that might be causing, any type of, popping sensation for this patient. But once again, we weren't seeing any abnormalities in this compartment either. Now moving on, once again, more ulnarly, we're going to be seeing the fifth extensor compartment, which is going to be containing the EDM. In this case, we were not seeing any abnormalities. And then lastly, to complete this is going to be the sixth extensor compartment containing the ECU, but once again, not seeing any abnormalities with this tendon either as far as tears or tenosynovitis. Now, then we're going to be kind of moving on to the joint structures for the wrist and the carpal region. I do think it's important to evaluate that distal radio-ulnar joint, just especially with any type of trauma, you can get instability at this region. And so this is then kind of pointing out that DRUJ at this area. Primarily what I'm going to be looking for is any type of, fusion, cortical irregularities at that area, or, potentially if there is any type of, step off or instability that you see at this region, or if they do have sonopalpation tenderness as well too. Then we're going to be moving on to the radiocarpal joint, evaluating that wrist joint recess. So this is going to be an example here for this patient that we see the radius lunate and capitate, but we're not seeing really any kind of joint effusion at this area, as well as any synovial hypertrophy or even any kind of cortical irregularities. So then this is going to be kind of then bringing us to the last area that I'll consider in my routine protocol, which is going to be that scapholunate joint and ligament. And so the easiest way I think to find this is really then, if you're on Lister's tubercle, you're just going to scan then a little bit distally and then ulnarly at that location. And then that will really then kind of bring you right to that dorsoscapholunate joint at this region. And so this is going to be an image that we see in this patient. And, right away, we're starting to see kind of several different pathologies that we'll go ahead and start to point out here. And so here within this image, we see on the left side is going to be radial. And so we have the scaphoid here, and then the lunate, which is going to be more ulnarly located. And then kind of pointing out then for this patient that there was complete disruption of that dorsoscapholunate ligament, which we can see here as that anechoic area going throughout the ligament. But another finding that kind of caught my eye as well too is that there's this hyperechoic foci within the scapholunate joint that's really kind of coming off that lunate area at this location. And so there's several different classification systems that you can use for these dorsoscapholunate ligament tears. The majority that have been described are actually, for wrist arthroscopy. So they really don't have a lot of correlation with ultrasound. But there was a classification system proposed in 2014 by Anderson and Garcia, which I think is probably the simplest to use and understand. And really, it just basically is classifying it as 4 different types. The first three types are going to be complete tears, and then just really defining where they're located. So type 1 is going to be a complete tear that's going to be more at the location of the scaphoid. Type 2 is going to be a complete tear where it's occurring more towards the lunate. A type 3 tear is a mid-substance tear, and then a type 4 is just going to be a partial tear within that ligament. And so for this case, it appears that for sure it's going to be a complete tear, and this is then going to be primarily within the mid-substance for this patient. I do like to also evaluate the scapholunate joint and ligament, especially the scaphoid and lunate, in a long axis view as well too. I've started to look at, especially if there are any type of cortical irregularities. And so once again, this is just going to be now a long axis view where we see that lunate. And once again, here's that kind of hyperechoic foci, which appears to be kind of a little bit of a periosteoavulsion that's going to be then coming off more than likely because of that dorsoscapholunate ligament tear. Additionally with this, when we're looking at any type of tears, that's obviously then when you can go ahead and get joint widening as well. So important to do measurements at that scapholunate joint. There isn't a lot of literature though to kind of point out exactly where we should be measuring these. There is several different locations that you can do this on, kind of pointing up in the picture in the upper right. You can do this centrally within the joint. You can do this dorsally. More often than not, though, I really just do try to go at the mid-substance of that dorsoscapholunate ligament and just be consistent for where I do my measurements. And so for this patient, the measurement was 7.6 millimeters. When you're looking at kind of standard reference values for ultrasound evaluation of the scapholunate joint, usually within normal limits is going to be about 4 to 5 millimeters statically. So anytime that you're definitely getting over 6 millimeters, that's going to generally be indicative of abnormal, pathology, and more than likely some type of tear that's occurring. But I do think it's always important to compare side to side as well too. And so if you're doing that, generally a 1 millimeter difference is also going to be indicative of pathology. And so once again, we kind of see the measurement here. On top of this, as I mentioned, I always like to do a contralateral comparison as well too. A lot of the time, I think this can make it, very obvious, the joint space widening. So in this image here, we see the abnormal scapholunate joint here on the left, and then we see the normal scapholunate joint here on the right. And when we looked at the overall measurements, once again, on the left, it was about 7.6 millimeters. And then when we're comparing on this more normal side, then it was around 4 millimeters. So we obviously see even already statically at this time that they're starting to get joint space widening. And then lastly, but kind of most importantly, as we had mentioned, the ultrasound, the added advantage compared to other imaging modalities, especially, X-ray as well as MRI, is it just allows us to evaluate this area dynamically. So there's been a lot of maneuvers that have been described to do this. For the scapholunate joint, the ones that typically are going to be performed is either radio and ulnar deviation. You can do a clench fist, but you can also then do a pencil grip view. I will say in my experience scanning a lot of these wrists now, I think I prefer doing the radio and ulnar deviation. It just really gives you, great control of the wrist. And I think it really puts the most stress, on this region. And so when you're doing this radio and ulnar deviation, usually what will happen is when you go into the radial deviation, this is actually going to cause more narrowing of the joint. And now then when you go into that ulnar deviation, that's when it's going to cause a maximum stress on that scapholunate ligament. And that's where you're going to see widening. And then also additionally, it's not just widening of that joint that you're going to see, but a lot of the time this instability can also be occurring in more of the vertical plane as well too, dorsally and volarly. So usually then when you're seeing this ulnar deviation, what's going to happen is that scaphoid is going to have a natural tendency to flex. And so that's going to go more volar, where the lunate is going to have more of a tendency to extend and go more dorsally at that location. And so what we're seeing here dynamically then is not only are we starting to see widening when we're going into that ulnar deviation, but we are actually starting to see the lunate start to kind of move slightly dorsally. And then in addition, really at the last part of this video, we're also seeing a secondary sign where we're getting some kind of joint fluid extravasation then going throughout that ligament as well too, indicative that there's a complete tear at that location. All right. So those are the kind of pertinent images then that we took from this case. So now, importantly, then going into the report that we had for this. And so these are kind of the key components that you want to make sure to, that you include. So first and foremost is that we performed a complete diagnostic ultrasound of the left dorsal wrist. Indications for this case was dorsal wrist pain and popping. The technical components were that we used both a linear array transducer, 15.5 megahertz, as well as then a linear array transducer with a small footprint with 18.8 megahertz width. And then now going into more of the findings that we saw from this case. As we had mentioned, these are going to be kind of the routine structures. And the main thing that we're seeing then pathology in this case was that scapholunate joint. And so what we saw here then was a complete disruption of that dorsal scapholunate ligament near the scaphoid. In addition, there was a small hyperechoic foci within that joint that was near the lunate. On static evaluation, we had saw that the joint was widening to 7.6 millimeters. And in comparison on the right side, this was 4 millimeters. And then importantly, when we were doing a dynamic evaluation, including radial and ulnar deviation, there was additional widening of that joint with dynamic instability. And then lastly, it was noted when we were doing this part of the scan that this is where the patient had the most sonopalpation tenderness present. And then in addition, just scanning over this entire area too, important to note that we did not see any ganglion cysts, which sometimes can occur with these ligament tears, which previously has been discussed in other lectures. So ultimate conclusion in this case was that there was a complete dorsoscapholunate ligament tear with dynamic instability. And so to kind of finalize this case, so this patient then went back to plastic hand surgery, and then they took her to wrist arthroscopy, which did confirm the complete tear of the scapholunate ligament, as well as in that kind of periosteoavulsion that we saw in the ultrasound. They ultimately underwent a successful scapholunate ligament reconstruction with capsulodesis. And so just kind of quickly, just wanted to discuss then the scapholunate anatomy as well as instability and really why this occurs. And so there's really kind of three main components of that scapholunate ligament. The one that we're going to be primarily evaluating on ultrasound, which is going to be the most important aspect, is actually just the dorsal segment. So this is going to be the thickest and most robust part of that ligament. So it's really providing the most stability. Now, obviously, the one downside of ultrasound compared to other imaging modalities is that we're not seeing more of the kind of interosseous or the palmar aspect of that ligament. But ultimately, these kind of two components do not provide as much stability to that ligament complex. And so usually, even if these are torn, they're not going to lead to significant symptoms for the patients. And so once again, ultrasound can give you, very valuable information, I think, of the most important aspect of that ligament. But I should note that there are additional kind of capsular ligaments within the dorsal wrist that do provide stability. So it doesn't automatically mean that if you do have a dorsoscapholunate ligament tear, you are going to have instability. A lot of the time you do have to also disrupt these kind of capsular ligaments. And the two main ones are going to be your dorsal radiocarpal ligament, which is going to be extrinsic to that wrist joint, meaning that it's crossing over from the radius to the carpal bones. But importantly, you're also going to have this dorsal intercarpal ligament, which which is going to be crossing over the carpal bones and is going to actually have a septum that's going to be connecting to the dorsoscapholunate ligament. So if this additionally gets torn along with that dorsoscapholunate ligament, then you're going to start to have, potentially even gross instability on static evaluation, on top of obviously having dynamic instability as well too. All right, well, that is the end of the talk. So I'll go ahead and open it up for any questions or comments that anyone may have.
Yeah, Stephen, that was fantastic. That was a really interesting case, and just overall a great presentation. Thank you for putting that together. I thought it was there's a couple of thoughts I have just on this kind of sort of clinical scenario and ultrasound in the dorsal wrist, and then also just looking at like an MRI, and that MRIs don't pick up everything. Just curious, in like retrospect, if you look back at the MRI, could you pick up that ligament injury or no?
No. I mean, that's what we went back to it. I even asked plastic hand surgery, radiology, and in discussion with it is, I will say they didn't use contrast. And so that's going to be definitely, when you're using these, a lot of the time they're going to be recommending that, just see if there's any extravasation. But obviously, the one downside is the MRI is the sequences are very small, as you're going through those. And this is a very small ligament. So a lot of the time, if it kind of just passes over, for whatever reason with the sequence that they're taking, I think that these can easily be missed just on conventional MRI.
Yeah, it's a great point. Like generally speaking, when you're looking at MRI slices, a lot of times the radiologist will protocol them that they'll have like thin slices through certain areas if there's a clinical question. And depending on also like the strength of your MRI scanner, right? Sometimes you'll get someone coming in with like a 0.7 Tesla MRI that is kind of grainy and looks a little bit like a CT scan, and you really rely on kind of active, edema and T2 to demonstrate some pathology, and sometimes you'll get someone with a really nice 3T scan and everything's pretty clear. And that's the same with ultrasound, right? There's different resolution of ultrasound machines, and so you definitely have to take kind of the technical limitations of a study into account when you're looking at it. And I think this is a great pickup and a great, referral from your surgeons to your practice, demonstrating that added value of kind of being able to examine the patient while you're looking at it. Just from like popping in the dorsal wrist, this is one that is sometimes challenging, and there's a lot of different things, that we see. And sometimes patient symptoms don't exactly correlate with, where the popping is coming from. Oftentimes people can tell, but sometimes it can't. And, definitely, going through the dorsal wrist compartments for something like this is really important. Just some things that, I've seen even just in the last couple of months attributed to that are, ECU instability is definitely one that I think should be a pretty standard, dynamic scan with most of these risk protocols, especially like dorsal or ulnar sided pain. People can get some impingement in the fourth dorsal compartment as well, and sometimes they can get some, especially with like a rheumatologic condition, some synovitis or thickening of the extensor retinaculum, and that can cause some symptoms similar to this. And then the other thing I've seen, which I hadn't before, and I was actually referred for a similar indication recently, maybe several months ago, was someone that had almost like an iliopsoas sort of snapping, where the muscle interposed between the second dorsal compartment tendons in the wrist. And then when they went to, I can't remember if it was extend or flex, the tendons wanted to drop back down to the bone and it snapped the muscle out. And so just being able to kind of look at, a variety of different things and asking the patient how they can reproduce their symptoms is really helpful. As far as just the scapholunate portion goes, that's a challenging one, right? We can see the dorsal ligament really, really well. And you can make a great call on pathology there, and you did. It always is a little bit of a question of, is it enough to just see that the dorsal ligament is intact? are there injury patterns where people tear the interosseous portion of the scapholunate without tearing the dorsal? And I've always wondered a little bit about that. I think the dorsal tends to be the one of the earlier injuries that are associated with the instability. And so um, when you look at those tears, though, measuring the joint width is challenging, and I've always struggled with this. I do a little bit different than you, and I don't know what is the right way. I think being
Yeah,
consistent is probably the right way.
unfortunately, I don't know if there is a right way. Like there isn't just too much literature on it.
Yeah,
When you're looking at this topic to say, what should be the standard. Like I said, I think the biggest key, as long as you're just consistent with the way that you measure it, is always going to be, really helpful.
yeah. I think the side to side view that you did is super helpful. That really tells a story. I tend to measure a little bit lower in the joint, and the only reason I do it that way is because kind of some of the standard values have been established on radiographs. And when you look at like the radiographs, you're going to see like that kind of most central bony contour is going to be where you take the measurement. And so that's where I've done it in the past, but I don't know, if that's correct. And then I've also, struggled, and I I thought yours was interesting. I've struggled with like the dynamic scan sometimes and feeling like I'm staying really nicely localized over the same kind of bony cortices when I'm looking for that dynamic instability. And I've gone back and forth between gripping and trying ulnar and radial deviation. With the ulnar and radial deviation, my experience has been that the patients can usually reproduce it best when they actively do it. Um, Compared to when I passively do it. But I have a harder time staying on the correct location when they're actively doing it. And so I've struggled a little bit with that, and I tend to do a lot of the like gripping or um sorry, gripping is primarily what I've done in the past. But once again, it's certainly an area that we need, better data on.
Yeah, yeah, there's definitely not a standard, this is the best, maneuver from that perspective. I just feel like, when I've stressed it, I've compared the views, and I just always feel like doing that ulnar deviation especially is where I'll get kind of the most widening and see the most gapping for that ligament. But like you said, it is a challenge, especially too, because as I mentioned, it's not just radial to ulnar instability that you're getting. You're starting to get volar and dorsal, instability, with the scaphoid and lunate. So they're shifting in both those planes. So no matter what, that is one area that I really like to use the kind of more broad width linear transducer, is because I do feel like you need a wider, view for when that's occurring, rather than using kind of that hockey stick or higher resolution, just because sometimes that's going to be a smaller field of view.
Yeah, definitely. Does anyone else have any questions or comments?
I guess, Brennan, I was actually going to ask you, do you have too much experience like scanning those kind of capsular ligaments, either the dorsal and a carpal ligament or dorsal radiocarpal ligament? I haven't seen too much literature out there for, scanning of those. But I think that is definitely, one additional area that ultrasound can probably be pretty helpful, especially as these patients are getting like more and more instability.
Yeah, that's a great question. That's something that at that a couple of recent AMSSM meetings people have been talking about and trying to do a little bit more scanning in these ligaments, especially on the ulnar side of the wrist, as it kind of applies to TFCC. And I've spent some time looking at them. The challenge, for me is it's sometimes hard to get a good anchor on each end of the ligament because they don't tend to just be like a straight ligament. As they run kind of in different orientations and cross over each other. And so I've definitely spent some time looking at those. I don't know that I would say I feel like I'm an expert in those at this point. Um, but yeah, it's certainly there can be complex ligament injury patterns, lunotriquetral ligaments and things like that I think are being more recognized at this point, from a pathology standpoint and a surgical standpoint that maybe we need to catch up or um, on with ultrasound. All right. Jake, I see you
Oh
unmuted.
yeah, I wanted to just tell Stephen that was a fantastic job with that presentation and case. Really interesting, and agree with all the points you guys have made. I was just curious, just digging in a little bit more about Stephen, how you're doing the dynamic scan. I'm kind of like Brendan. Of course, we practice together now, but I tend to use the squeeze method more often. I think just because with these dynamic moves, I think sometimes, at least I've found it helpful to try to minimize movement as much as possible, because I think sometimes you can introduce a little bit of error if there's some if you get off of the same points from your baseline to your stress measurement. But I was curious, when you're doing the radial ulnar deviation, are you having this done actively, or are you doing it yourself? Are you having an assistant do
No,
it?
usually I would try to do it, myself. And so usually then I'll just try to almost like a Watson test. I mean, to be honest, I really just try to grip, over that kind of dorsal wrist, area, obviously not directly over the scapholunate, just because that's where the transducer is. But then that's where, I'm having them usually kind of at least resting on a table, so their hand isn't kind of completely going into flexion. But then, really trying to move them then into, especially that radial and ulnar deviation. But like you said, it's a challenge, because that scapholunate ligament area is very small, and so it definitely does sometimes take a couple a couple scans to really get a good view of it. But I just, once again, I feel like once I stress them more into that ulnar deviation, that's when I've been able to see kind of the most gapping for that ligament.
And then it sounds like you're using absolute values rather than like a stress delta.
Then you're talking, yeah. So I'll scan both statically, and then dynamically as well too. In this case, I didn't get the exact measurements dynamically, but if it's a very kind of close case, then I'll just do usually maximum measurements when they go into ulnar deviation and compare it where they were at statically. And usually for that measurement, I'm then classifying instability as anything greater than 1 millimeter difference from static to dynamic.
Great. Yeah, I think the side to side as well is key, especially if you don't do a ton of these, and obviously just with variability between patients, the side to side I think is key with this one.
Yeah, no, 100%. This is definitely one of the first cases that I saw as far as the dorsoscapholunate, and it made it so obvious that if you do have an asymptomatic side, that's just another benefit of the ultrasound, is that you can just do a quick contralateral comparison.
All right. Fantastic. Well, I think we'll end it there so everyone can get to their clinics here. But yeah, once again, gosh, that was fantastic. Thanks for doing that. We'll be back in a couple of weeks. October 13th, Friday, October 13th, we have Dr. Jacob Jones. He'll be presenting on a lateral ankle avulsion. I'll be away that week, and Stephen will be taking over for that presentation. Thanks.
Thanks.